Right, okay, hand infections or infections of the upper limb. So you want to start with your basic investigations every single time. Okay, you want to start with white counts. You want to start with a CRP, because if they're trending downwards, that's a very good thing. Okay, you don't want to forget that you need to mark the area that has inflammatory changes on the skin and write a date on it. As you can see, I've written the date. I didn't write the hour, which is also important in very rapidly expanding infections. You want to also take some liver function tests and some kidney function tests, because that is important, because some of the antibiotics that we use depends on the function of these, and also antibiotic can influence them. You also want to do a bit of imaging. So you want to do x-rays to see if there is any foreign bodies that has been visible on x-ray, any fractures. MRI is very good for osteomyelitis, but CT can also be super helpful. Now, I want to tell you a little tale of imaging. 43-year-old female, road traffic accident a year ago, nurse, fat right thumb, very painful. She's had a couple of short-term antibiotic courses which did absolutely nothing. Presents about 4 months after this thumb has started swelling up, and it wasn't actually involved in the road traffic accident to start with. So because we think it's an osteomyelitis, she has an MRI in March of 21, which shows inflammatory changes, which probably is osteomyelitis. She goes on to have an X-ray in April, which shows a cortical destruction. She goes on a 6-week course of antibiotics. In June, I get asked to, so she has an antibiotic pause because this doesn't seem to have helped. In June, I get asked to take samples for everything. And in this, I get nothing back. We send it for AFB, all sorts of things. She gets put on a high dose ciprofloxacin for 2 weeks. This has a CT scan in August 21, at which point there is a fracture which is attributed to the previous osteomyelitis. The patient attributed to me taking my samples, unfortunately. Anyway, she still gets better, and in December 21, she has another CT scan which shows a complete united fracture, and there's nothing else to see on inflammatory markers or anything. And I've just seen her a couple of weeks ago, much better thumb, much less swollen, and no pain really to talk about. So both CT and MRI and X-ray, because I would have said that the X-ray in April looks like there is a fracture there, but who knows? But she got better. Now, there are risk factors for infections, of course, and most of those are to do with an immunocompromised state, including the use of steroids, including intravenous drug abuse, diabetes, massive factor, vascular insufficiency, not so much, but diabetes is connected to strep bacteremia, especially if it's been a long-term diabetes, if it's poorly controlled. And so it's super important to have that perioperative glycemic control. You want to send specimens, and please don't send them the whole finger like I did, because I got a very prompt call from microbiology saying, don't do that, just send us a little specimen. But you want to send specimen for gram staining, for aerobic and anaerobic cultures, for staining for acid-fast bacilli, and for mycobacterial cultures, and for fungus. Now, usually they'll give you a report back in 24 hours, but if there are very few bacteria in the specimen that you've sent them, it might take them 48 hours. The other thing to think about is that fungal specimens take about 10 days to culture, and mycobacterial cultures take about 6 weeks. So there is a time thing, and you need to speak to the lab if they want specific media or specific containers to send these in. Right, so do we treat all results? Well, no, not really. I mean, there might be other reasons for why we want to give people antibiotics, like the exposed bone here from a road traffic accident. But if you get a swab results back with Pseudomonas, you don't necessarily have to treat it if it's a long-standing ulcer, because, you know, Pseudomonas is a colonizing bacterium, and you can treat it topically if need to. Staph epidermidis at the same time, also not particularly dangerous unless you have metalwork. Now, if you have metalwork, or if you have silicone implants in hands like Swanson's arthroplasties, then it becomes dangerous. Then we don't want to have that. Then we want to talk about the most common bacteria than there are. So there is Staphylococcus aureus, by far the most common bacteria. I want to talk about MRSA and Panton Valentine leukocidin toxin, or PVL for short. Now, people who get MRSA are people who've been in hospital for a long time, that have had loads of antibiotics for all sorts of reasons, not necessarily to do with surgery, but people that have had loads of surgery can also get MRSA. People who had a chronic illness, intravenous drug abuse, again, or people from crowded environments. So people like soldiers, homeless people, people who live in very, very close quarters with others. Now, less than 2% of Staph aureus produce PVL toxin, but those who do create really, really nasty infections with lots of bacteria, lots of, abscesses. They're difficult to get rid of, and people get very sick. Now, the reason that PVL is important is it's a combined of two things. It has a Leuc S subunit and a Leuc F. So if you want to say the foot and the shoe, and together they make punch holes in the leukocyte. So this is a slightly more, scientific, if you want to have representation of the same, but obviously the leukocyte doesn't fare well from the punching of the hole in it. That's why PVL is very bad. And if you have patients who have PVL, then you really want to cure them. And then afterwards, you want to treat them long-term with stuff up their nose and stuff for washing so they don't get it back again. Polymicrobial infections are the next most common thing. We commonly get them from bites, and mouths are the most dirty things on earth at all. So you have particularly Pasteurella, which is in about 50 to 80% of cat bites, but also 25% of dog bites. Dog bites has another potentially fatal infection with capnocytophagia, and I'm not even going to say the last one because fatal infection in immunocompromised hosts. You see the sort of theme here. Now, human bites have a unique thing. They have Echinella corrodens, and they also have 40 other bacteria in them. And you must think about them every time you have any contact with a mouth. We specifically talk about fight bites, which I'm sure you've all considered. Then there is also, for bites specifically, the method which the bite is produced. So cats have long, thin fangs. There is with the dog, it's more of a tearing bite. So they do produce more tissue damage, dogs. And on average, there's about 2 to 20% of dog bites that get infected. But if you look at hand dog bites, that percentage is much higher. Then with bites, you also have to think about Hep B, HIV, although the saliva that the HIV person bites you with has to be mixed with quite a lot of blood to get anywhere. And then we'll get, and this is a pet topic of mine, fish, right? So this is a piranha, not that often, but I have seen a piranha bite. And the guidance for this is that you try and cover everything, and give them something like ciprofloxacin. I'm sorry. So fish are bad animals in the biting environment. We talk about strep, the two types of strep. That's the next most common infection. So we've got staph, polymicrobial, and strep. Strep has strep pyogenes, which is particularly bad. It can lead to very, very sick patients, amputations of fingers, toes, hands, legs, and strep agalacticae. They're also, which is a little less bad. And then there is C and G, I believe, which are not that involved in the infection range. There is also tetanus. So anywhere where you have devitalized tissue, you have to think about tetanus. So any compound fracture, anywhere there is burned, for instance, or anywhere that you haven't debrided enough. And I had in my notes written down how to say this word for the tetanus posture that is depicted here by Sir Charles Bell, and I think it's opisthotonus. But keep up with your tetanus shots. It's super, super important. We need to talk about a little bit about war and what was called the Green Zone, which was in the Helmand province. And this is bad because there is a combination of things. There is a particular bad destruction of tissue with IEDs because of the blast injury. Then these soldiers have crawled through lush vegetation, standing pools of water. Let's say personal hygiene isn't that, good at that point. They're catabolic, which means that they become immunocompromised. And why they're catabolic? Because they expend an enormous number of calories running around, being physically active in a hot, warm climate, hugely stressed out. If you take the normal parameters for infections such as SIRS, the inflammatory response, or look at white count, which is usually normal unless you have an abdominal injury as well, then it's probably better to look at the CRP count to see what will, how it's going. Now, CRP isn't the isn't the final answer in looking at. You have to have looking at the physical appearance of the patient. They have to go back to the OR or theatres every 48 to 72 hours. You have to debride everything. It's called marginal debridement. So you leave things that you think might recover. For the upper limb, you do it under a tourniquet. And what we're afraid of here is the zygomycetes. So the zygomycetes looks like, they sound like a pop band, but they're really vicious, although they look quite cute there on the drawing, because they cause necrosis of blood vessels and they cause necrosis of tissue. So now when soldiers are in that environment, the military and the doctors have provided with a sort of preempting treatment of fungal infection that is done with IV antifungals. So let's talk about acute infections. So there are different ones. So there is cellulitis, which is an infection of the skin of the hand. There is no abscess. You treat it with antibiotics, physiotherapy, hand therapy, and a resting splint. You got paronychia, which is usually treated with incision and drainage. It's very painful. Then you got phelon abscesses, which is exemplified by the thumb here. They're excruciatingly painful because there's a lot of pressure between those septae in the pulp. They can be cut open from the side as a fish mouth, over the pulp, whatever gets the pus out. They can also cause osteomyelitis, and they can also cause flexor sheath infections, which are exemplified by the index finger here. And my personal preference is to make a small nick here at the DIP joint, possibly at the PIP joint, and down by the A1 pulley. I know that some people open them up with a Brunner incision, but I have seen the whole of the volar surface of the finger die off. It might have died off anyway, but I think that if you make a small incision and try and wash it out that way, you can always make it bigger later if you need to, but you can't make a bigger incision smaller. So the reason we want flexor sheath to be taken into theatres immediately is because the pressure inside the sheath and the bacteria inside the flexor sheath fluid kills off the tendon. So you have tendon ruptures. Interestingly, when I worked in Denmark, I saw a particularly bad flexor sheath infection, which had ruptured through to the palmar skin. And that person did absolutely lose his flexor tendon. There are, of course, the 4 cardinal signs of flexor sheath infections. So you have a fat, warm finger, it's fusiform, it's tender if you press on it, but if you try and extend it passively, then they really don't like it because that is excruciatingly painful. Septic arthritis is also an acute infection. It can be from a fight bite, it can be hematogenous route, and if you have sexually active patients, you also actually have to think about gonorrhea. You are best getting a sample of it, but otherwise you need to take it to the OR or the theatres and wash it out and treat them with antibiotic, because this can really, really destroy small joints. Talk about osteomyelitis is also an acute infection. So this was a lady I've also seen recently who presented with a little bit of pus underneath her nail if you sort of squished it a bit. So she was sent to me for a biopsy to exclude osteomyelitis, took an x-ray. So no points for guessing which finger this is, which finger is the problem. And there was no distal phalanx. So apart from sending it for, of course, the specimens that we've talked about, you know, she does not have a distal phalanx anymore. Usually it's Staph aureus again, but she grew Pseudomonas and Enterococcus and was treated with captazidine and vancomycin for 6 weeks. Now, we also need to talk a little bit about deeper spaces. So let's concentrate on the B drawing first. So the gray bits are the bones. The brown bit, I apologize, is the pronator quadratus. The red bit is the space of Perona, which you can also see on the A drawing, which is very proximal on the wrist. Now, all the green blobs are tendons and the yellow ones are nerves. So lots of flexor tendons and extensor tendons. So on the A picture, this is a depiction of all the flexor sheaths. And in this particular picture, the index, middle, and ring are separate, and the little finger is separate, but doesn't seem to connect with the thumb. But some clever people did a lot of dissecting and found a lot of different variations of this. But the winner is, with 71.4%, is something that connects the little finger and the thumb flexor sheath. So this explains exactly why you get what's called a horseshoe abscess. We find all these names. Anyway, so you have a little injury from the thumb. It travels down the flexor sheath of the thumb, and then it goes into the Perona space, which is down here, and then up the little finger. So you have to keep cutting until you get something that's clear. You've got to go more and more proximal until you get clear, and then you wash like crazy. You also need to have a think about, so these are the flexor sheaths that are sitting up here. These are the metacarpals, and below the flexor sheath are the mid-palmar space, and then there is the thenar space as well. So there are spaces that are even deeper than the flexor sheaths. Chronic infection, Mycobacterium marinae. This is also from Canada, from a fish tank. I told you fish were dangerous. So this lady represented, so she is immunosuppressed, she is on chemotherapy, which is why she presented a couple of months ago to my colleague's clinic. We share the same space, and I was there from the morning and he is there in the afternoon. And actually it was my brother, who's a dermatologist, who helped me diagnose this when I sent it to him. So this is her a couple of months ago. She gets treated with rifampicin and antituberculous, drugs. And this is her progressing. So you can see she still gets some lesions. Let's see, okay, so here's a close-up. She still gets some lesions. She says they pop and then they become all right. And if you want, so this is a pearl necklace plant. There you go. And this is supposed to be like beads of pearl on a necklace. This is very characteristic of Mycobacterium marinae. This is another fish tank. This is a diabetic, smoking, vasculopath who swore like a trooper and who came in with both his hands infected, which he had done absolutely nothing about. Then he had an incision drainage in the emergency room. Then he came to me, and slowly and surely, every time I let him go home because he wouldn't stay in hospital, he came back with more infection and deeper infection, and he ended up with an amputation at the carpal level. Now, all of his surgery was done under local anesthetic in the clinic because there was no way I could get him to the main theatre apart from the last one. Now, he hasn't been back, but I'm not sure that's because he doesn't have another infection. He may just have chosen not to come back to me. I appreciate that. His other hand was also had an infection, but fared somewhat better than this. This is Buruli ulcer, which is endemic in the tropics. So West Africa, Australasia, it has to be tropical, lush, high humidity, low oxygen. We think it needs to have, it may be transmitted by mosquitoes. And if it's treated early or caught early, when it's a subcutaneous nodule, it can just be cured by antibiotics, which is why it's heart-rending to see when people are not treated appropriately early on. And talking about chronic infections, we also need to think about the outcomes of a long-term Buruli ulcer, which is a lot of scarring and a completely dysfunctional hand. Mycobacterium leprosy, chronic is also, so it's a disease of the skin and the nerves, and it's diagnosed by a tissue biopsy with a skin biopsy, which you send for histopathology and for microbiology. You early on, you can do stuff like releasing nerves, like a carpal tunnel decompression and releasing abscesses. But as the disease goes on, you're going to have to do some tendon transfers to make hands useful. Couple of more chronic infections, actinomycosis, which is a purple little ulcer that may or may not have anything to show on x-ray. So I haven't seen any of those myself. So this is borrowed from the internet, from my peers. There is no destruction of the bone in this x-ray. But actinomycosis particularly presents as a small purple ulcer, gets better with antibiotic, but as soon as you stop the antibiotic, it comes back. So you need to culture what comes out of that little purple ulcer and little eruption. You have to tell the lab that you are expecting that this is actinomycosis, because they will have to culture it anaerobically for the first 10 days. So that's super important. You can't just send it to them and hope that they'll do the right thing. The other thing is sporothrex. Again, I have to attribute it to my colleagues in Italy, which is to do with soil. It is to do with gardening, rose thorns, all of that. And you can see that again, that you have this, that you remember from the Mycobacterium marinae infection that looks like a pearl going up the arm. More chronic osteomyelitis, which can cause swelling, inflammatory changes, open wounds, sequestra, draining sinuses, or just plain exposed bone like here, where your debridement has to be really radical and therefore can be quite destructive. So you might need to reconstruct unless you want a one bone forearm, in this case, you have to reconstruct it with some free bone graft or vascularized bone graft. But if you get this early enough without cutting it out, it takes about, they need to have IV antibiotics for about 6 months. Onychomycosis is probably something that we see slightly more often. Okay, usually it's misdiagnosed. A lot of people get it thinking it's or we get sent them because they think it's a subungual melanoma. You need to send off scrapings in that little black envelope to the lab, and you need to treat it until the nail has grown out. And the nail on the finger grows about 3 millimeters a month, more or less. So it's going to take quite a few months before that grows out. Paronychia can also be chronic, especially in people who have their hands in water for a lot of the time. So also the second thing that's important is that you have lost the eponychial fold, the cuticle that you get pushed back in the nail bar when you get your nails done. That's actually meant there to be there as a good thing, because it keeps bacteria out. And chronic paronychia are often polymicrobial, and there is again a little bit of candida in there. But if you just treat it with antifungals, that's probably not going to be enough. Well, it usually isn't, and you have to marsupialize it. You can use topical things for it, but again, long time, and stop putting your hands in the water. Viruses, herpes, can be mistaken for a acute paronychia, especially in kids. And so the question is, should you incise or drain it? If you think it's viral, then no, because you might introduce bacteria as a secondary infection. And sometimes if you're lucky, you can see small little vesicles, and anybody that's ever had a sorry, cold sore will know that this is that you get these small vesicles. You can, of course, also get shingles of the upper limb, and you can get foot, hand, and mouth disease, which will also give you blisters and a viral thing on the hand. Postop infections are, thank God, rare. I try not to give my patients antibiotics if it's an elective operation. I do if I leave metal behind. This is a Dupuytren's disease, which got infected, but have a low suspicion, you know, treat early, open your incision up and wash, wash, wash. As an aside, patients in Canada gets 2 grams of Ancef, almost stat, every time they hit the OR. Doesn't matter how big or small they are unless you say you don't want it. This lady's regained most of her range of movement, and I see her often because she's a theatre sister in my department at the hospital where I work, and she's regained most of her range of movement thanks to my wonderful therapists. Necrotizing fasciitis, of course, can also happen of the upper limb. This lady I met on my very, very first night on call in Canada. She was a smoking, tough Canadian who'd gone to a GP with a little bit of pain, and now she was in emergency. And she said, "All right, Dr. Barb." And then we went to the OR. I've never seen anything move so quickly, but got her debrided, put a vac on, and then put some skin graft on, which you can see hasn't really taken, but the nurses got it to heal eventually. Probably didn't help too much that she was smoking either. Anyway, things, infections are not also which are worth thinking about. Gout is not an infection, so you need to take urate, you need to test, you need to take some x-rays. Pyoderma gangrenosum looks very alarming, is not an infection either. Thorns, which are lodged, or foreign bodies like wooden splinters, are, I suppose, localized infections, but not real infections that you have to treat with antibiotics. You just need to get rid of them. And then fractures can also mimic infections. So final points here are: take samples, send them for everything, debride and wash properly, optimize your patient if they're sick, treat with correct antibiotics, preferably, because the mortality if we treat with the wrong antibiotics is far higher. And that's it.